All right, so today we are starting a new topic in chapter 18, in which we've covered a lot about the anatomy of the heart and the physiology of the cardiac muscle contraction. Today we are starting a physiological topic, which is the cardiac output. What's cardiac output? Cardiac output is the amount of blood pumped from the ventricle in 1 minute. So again, what is cardiac output? This is simply the volume of the blood pumped from the ventricle in 1 minute. How do we calculate the cardiac output? The concept is so easy here. If I want to know the amount of blood that got ejected from a ventricle in 1 minute, what will I do is I will check the amount of blood that I've pumped in a single cardiac contraction, which is the stroke volume for 1 beat. And I will check how many beats, how many cardiac contractions did take place in 1 minute. And the number of beats per minute, this is simply the heart rate. So generally speaking, what is going to be the formula here, or the equations that we're going to be using to check the cardiac output? It's going to be the heart rate times the stroke volume. Heart rate is the number of beats per minute, and stroke volume is the amount of blood pumped in 1 beat, in 1 cardiac contraction. At rest, cardiac output is about 5 liters per minute. So your ventricle pumps around 5 liters per minute. This can go up 4 to 5 times, and we call this the maximal cardiac output. Maximal cardiac output can reach 35 liters per minute in trained athletes. They can increase the heart rate. They have better cardiac contraction, which will let them eject more blood in a single beat. So they have higher stroke volume, they can reach higher heart rates than a regular person. So the cardiac output can reach 35 liters per minute. On the other hand, a regular person will reach about 35 liters per minute as a maximal cardiac output. The difference between the cardiac output that you are currently pumping and the maximal cardiac output, which is the maximum amount of blood that you can pump per minute, this is what we call the cardiac reserve. And this is your reserve, so you will not use it unless you need. So whenever you run a sprint, for example, you're going to need definitely much more blood to be pumped towards your muscles. So this is the time for you to use your cardiac reserve. The amount of blood that you're not going to be pumping, this is a regular or resting cardiac output. And the maximum amount of blood that you can pump in a single beat, and this is the maximal cardiac output. And the difference between those two, it's your cardiac reserve. So how would I be able to calculate the amount of blood that I pump from my ventricle in a single cardiac contraction per beat, stroke volume? How would I be able to calculate the stroke volume. An easy way to do this is to check the size or the volume of the ventricle at the end of relaxation. So we call this as end diastolic volume. What is end diastolic volume? It's the volume of the ventricle after it maximally relaxes, after complete relaxation. So what I'm measuring now, I'm measuring not only the volume of the muscles and tissues forming the heart, but also the blood volume kept inside this ventricle. So when I measure the end diastolic volume, what is this volume actually? It's not just the muscles of the wall of the ventricle, it's the muscles and tissues of the ventricle, as well as the blood volume kept inside this chamber. And I will subtract this volume, I will subtract the volume of just the heart without any blood from the end diastolic volume. So when would I have the volume of the heart tissue without any blood inside? At the end of the ventricular contraction. So we call this is my end systolic volume. So again, how would I be able to check the amount of blood that I pump in a single cardiac contraction per beat, stroke volume? I need to measure the end diastolic volume, which is the volume of the heart at the end of the relaxation. Means what? Means I'm checking the heart plus blood inside. End diastolic volume minus end systolic volume. So end systolic volume here is going to be mainly the heart tissue without the blood that got ejected out. The difference between the two is going to be simply the blood that got ejected. And this is what I call again my stroke volume. So again, what did we mention so far? We mentioned cardiac output, and this is the blood that gets pumped from a ventricle in 1 minute. And we agreed that this can be calculated by checking the amount of blood that we pump per beat, and we multiply this by the number of beats per minute. We then stated the stroke volume. Stroke volume is the blood pumped per beat, and in order for me to know the amount of blood that got ejected from the ventricle, we're going to be checking the volume at the end of the relaxation and diastolic volume, and we're going to subtract from this volume the volume of the heart tissue itself, and this is going to be the end systolic volume, the volume of the heart after it completes its contraction. Looking here at multiple factors that will affect the stroke volume and thus the cardiac output. First factors that we're looking at today is going to be preload. What's preload? Preload is simply the amount of stretch that is applied on the heart before it contracts. In other words, what? In other words, if this is my ventricle, the preload is the amount of blood that's going to be reaching the ventricle for it to be filled. And this amount of blood is going to be stretching my ventricle. We call this is my preload. The load that I put on the heart pre it contracts, before it contracts. And this will be applying the stretch on the wall of the ventricle. So how preload gonna be affecting here my stroke volume? Let's say I have increased preload. How's this gonna affect my stroke volume? If I'm getting more blood in before the heart contracts, what do you think gonna happen to the amount of blood that get ejected from the heart? If I increase the amount of blood coming in, would I get more or less blood out? What do you think? Just logically. So more blood in means more blood out, right? This is logically. How can we check this? So if I increase the amount of blood coming back to the heart, my venous return, preload, which one got affected, do you think? The end diastolic volume or the end systolic volume? Again, what is end diastolic? End diastolic is the volume of the heart at relaxation, after it completely relaxes. And what is end systolic? This is the volume of the heart after it completes its contraction. So which one would it be affected? As I increase the blood going towards my heart, which one gonna be affected? End diastolic or end systolic? When do you receive blood? When you relax or when you contract? When you relax. So this means what? Which one gonna be affected here? The volume of the heart at the end of relaxation or the volume of the heart at the end of contraction? So I got only 2 responses for my question. I'm waiting for more. Exactly. And diastolic volume. So I receive more blood. So the volume here of the heart is gonna be, of the ventricle, is gonna be expanded because simply I am receiving blood in. And the volume that's gonna be expanded is gonna be the one during which you are receiving blood, which is your end diastolic volume. So what's going to happen as a result to the stroke volume? So if we look in here, stroke volume is end diastolic volume minus end systolic volume. So let's do numbers here to make it simple. 5 equals 10 minus 5. If I've increased this 10 and I'll make it 15, let's say, what's going to be my stroke volume now? Fifteen minus 5 is going to be equal to 10, exactly. So what happened here to my stroke volume? The amount of blood that I pump per beat. It went up or down? Up. So you see on here, when I increase the amount of blood returning back to the heart, I increased the preload. And as I increase the preload, what happens to the volume of the heart at the end of relaxation? It goes up, and diastolic volume. And when the volume of the heart at the end of the relaxation goes up, what's going to happen to the stroke volume? Stroke volume goes up. So what's going to happen to the cardiac output? Can you remind me, what was cardiac output equals to? Cardiac output equals to stroke volume times heart rate. So if I'm telling you that stroke volume did go up, how is this going to affect my cardiac output? So let's say here 5 and 10 equals 50. If this 5 becomes 10, so now what happened to my cardiac output? It's 10 times 10, which is 100. So you see on here, what happens to your cardiac output when you increase the stroke volume? Cardiac output will go up. Does this make sense? All right, great. Moving on, looking at another factors that affects the stroke volume, which is the contractility. In other words, how strong am I contracting? I'm squeezing the ventricle. How strong am I squeezing the ventricle? If I told you I have an increase in contractility, so I've increased contractility, I've given a medication to a person, and this medication is supposed to increase contractility. So what do you expect to see? It's positive inotropic, means it increases the force of contraction. What do you expect to see resulting from the increased contraction? A change in end diastolic volume or a change in the end systolic volume? So will there be any change in the volume of the heart when it's relaxing if I increase the force by which I contract? No, no change. So this is going to remain the same. How about here? If this was my regular contraction, I still have some blood remaining after I contract. I told you I would be increasing the force of contraction. So now I have nothing left. So what is going to happen to my volume as I increase the contractility here? What's going to happen to the end diastolic or the end systolic volume? This is the one that's going to change. As I increase the contractility, more blood is going to be squeezed out. And you see here, the volume of the heart at the end of the contraction is going to be reduced. So increase force of contraction, increase the contractility of the heart. This will reduce the volume at the end of contraction. And systolic volume is going to be reduced, not increased. More contraction, more reduction in the volume. So let's check on here's the effect on stroke volume. So let's do it with the same numbers like in the previous example. So I have an end systolic volume now rather than 5. It's going to be going down to become, let's say, 2. This is what have changed. So what do you think gonna happen to my stroke volume? So stroke volume was 10 minus 5 is equal to 5. Now it's 10 minus 2 is equal to 8, right? So what happened to my stroke volume? If you compare it before you increase the contractility. So stroke volume goes up. So if I increased contractility, what happens to my cardiac output and stroke volume? Both will go up. So stroke volume is gonna increase, as you see on here. Any problem with contractility? Any problem with preload? So if I increase preload, stroke volume goes up. If I increase contractility, the end systolic volume will decrease. As the end systolic volume decreases, stroke volume is gonna be increasing. Let's see a third factor. A third factor on here is going to be the afterload. What's afterload? Afterload is the resistance facing the heart in order for it to eject the blood out. So this is the resistance I need to overcome for the blood to move out. So what if a person has hypertension? This means what? This means that I have high blood pressure in my arteries. So if I have high blood pressure in my arteries, this means what? This means I have higher resistance against the ejection of the blood into my arteries. Higher afterload. All right, so how's this going to affect my stroke volume? If I have more resistance to pump this amount of blood out of the ventricle, what do you think? Would I be able to pump all the blood that I have inside, or as I have more resistance facing me, less blood is going to be ejected? What do you think? Less blood going to be ejected. So it's like if you are applying to a job that everybody is applying to, so your chance of being accepted to this job is going to be decreasing. So the same concept on here. I have a lot of resistance facing me, so less blood will be able to become ejected compared to if I don't have the same resistance that I need to overcome. All right, so same concept on here, same concept on here. So which one going to be affected from our stroke volume formula on here? Will it be the end diastolic volume or the end systolic volume? Which one going to be affected? Which one going to be affected? If I'm telling you that not all the blood that I use to eject, pump, gonna be able to move out of the ventricle. Now this tells you that which one gonna be affected, which one here, it's gonna be my end systolic volume. So what happens to the end systolic volume? Will it increase or decrease? I told you, you normally ejected all this amount of blood out. But because now I have hypertension, I have a lot of afterload that I need to overcome, there will still be remaining some blood inside. So this is without having any hypertension. This is when I have hypertension. So less blood gonna be ejected. But what happened to my end systolic volume? The volume of the heart, of the ventricle after it contracts, would it be larger or smaller compared to if I don't have hypertension? It's going to be larger. So what happens here to the end systolic volume in case of an increase on an afterload, the end systolic volume is gonna increase. So higher end systolic volume. So how's this gonna be affecting my stroke volume? So stroke volume is, let's do the same numbers. So 5, 10, and 5. So if I'm telling you that end systolic volume is going up, so rather than being 5, it's gonna be 7. This is a change. So now, how is this gonna be affecting my stroke volume, the amount of blood that I can pump per one beat, one cardiac contraction? So 10 minus 7 is 3. So what do you think happens to my stroke volume when I have hypertension, if I have high afterloads? With high afterload, what happens to your stroke volume? It decreases, exactly. Stroke volume gonna decrease. And this explains why one of the early signs that will bring symptom that will bring the patient to the clinic with hypertension is that he has tachycardia, fast heart, tachy, fast, cardio heart. So tachycardia, so this patient has tachycardia. Why? Why does he have increase in his heart rate? What do you think? Trying to get more blood delivered, exactly. So remember, cardiac output is equal to what? Stroke volume times heart rate. What happens to the stroke volume if I have hypertension? If I have high blood pressure, my stroke volume is gonna be decreased. So in order for me to deliver the same amount of blood to my organs, to pump the same amount of blood per minute for the organs to get whatever they need, what will I need to do? I will need to compensate the reduction in stroke volume by increasing the heart rate. See on here, if the cardiac output here was, let's return to the same numbers. So here, stroke volume, it was normally, let's say, for simplification, 5, and heart rate, let's say it's 10. So normally it's 50. If I did have a reduction on here, so I want to have something. So let's say its heart rate was 3. So 5 times 3 is going to be 15. I want to maintain the same cardiac output, which is 15. But I did have a reduction in my stroke volume. So rather than 5, it becomes 3. So in order to have the same 15, the same cardiac output, what should I do? You see on here, I need to increase this 3 into 5 in order for this to be 5 times 3 equals 50. All right, so why patients with hypertension will have tachycardia? Because an increase in the heart rate will compensate the reduction in stroke volume. Will compensate for the reduction of stroke volume. Questions? All right, so again, what we're looking at in here, we're looking at 3 factors that will be affecting the stroke volume. First one is the preload, and again, this is the degree of stretch applied to the cardiac muscle cells before they contract. In other words, it's going to be the amount of venous blood returning back to the heart, venous return. This impacts the end diastolic volume. About contractility. Contractility is a contractile strength by which a given muscle length will be reduced independent of muscle stretch and diastolic volume. So again, in other words, this is how strong am I squeezing the blood out of the ventricle. What is afterload? What's afterload? Afterload is the pressure that I need to overcome for the ventricles to eject the blood. And this is going to be impacting my end systolic volume. What happens with hypertension? I have an increase in the afterload, and this results in an increase in the end systolic volume, and as a result, I will have a reduction in my stroke volume as we've discussed in here. For question number 1 today, for your in-class activities, please answer this question on here. What term describes ventricular contraction? What term describes ventricular contraction? It's systole or systole. How about ventricular relaxation? It's going to be diastole or diastole. Questions? All right, so moving on to the homeostatic imbalances related to the heart. First, I have the blockage of circulation. The blockage of the circulation can cause angina pectoris, which is going to be pain in the chest. It's due to deficiency in the blood delivery to the myocardium. And cells here are going to be weakened. So I can see here what you're saying. Is all will be on the test. What will be on the test? What we've discussed, the cardiac output. Yeah, like everything is going to be covered by one way or another on one of your exams. Yes. All right. So for this is not a lab part. This is a lecture part, and this is going to be covered in the lecture exams and quizzes. And for the question again, question 1, which term describes the ventricular contraction? All right, so again, we're looking here. No, I didn't say 2, just 1. All right, so we're looking here at the homeostatic imbalances related to the heart. First set of homeostatic imbalances, this is going to be the angina pectoris, which translates into chest pain. All right, thoracic pain, and this is going to be due to deficiency or reduction in the amount of blood that gets delivered to the cardiac muscle cell. So if we're looking here at the wall of the ventricle, if I do have reduction in the diameter of the coronary arteries due to accumulation of fat in their walls due to atherosclerosis, what's going to happen to the amount of blood that will be capable to reach the cardiac muscle cells now? It's going to be reduced. So I have less blood that gets delivered. And as less blood gets delivered, the cells here will not be performing well, but they will not die. They will be just weakened. So can I treat those cells? Can I do anything about this? Here's a vessel. Here's a vessel. It's not blocked. It's not blocked. It's just narrowed. Can I treat this? Case of angina. Yes. How? Stent, exactly. So I pass with a catheter. I will take medications to reduce the risk of developing a blood clot. So I will put the patient on low-dose aspirin or clopidogrel. But also I can put a stent, as you mentioned, put a stent to dilate the vessel, to widen the vessel, and the blood will be able to get back to the cardiac muscle cells, which won't be weakened anymore. So they can work fine. All right. So what will I do is I put a stent. So, but I cannot just, I cannot just pull the fat out. I can just put a stent, and this might be a medicated stent that keeps releasing uh, anticoagulants for this patient to have a reduction in the risk of developing a myocardial infarction. So what is myocardial infarction or heart attack? A myocardial infarction is going to be due to a coronary blockage. Here, I've got a block. So this vessel is not only narrowed, like in the angina. It might have started as atherosclerosis, where the fat is accumulated like this. But at a certain point, what happened? This atheromatous plate got ruptured, and it created an attachment surface for the platelets to be attached to. And those platelets got activated, started to attract more platelets, and a blood clot was formed in the vessel, blocking the blood supply going to those cells. So what happens to those cells if they don't have any blood supply? Those cells are dead. And those dead cells cannot be repaired because the cardiac muscle cells are permanent cells. So you cannot regenerate the cardiac muscle cells. Instead, they will be replaced with fibrous connective tissue. All right, it's not contractile. It will not be helping with the ejection of the blood. It's like a seal that gets formed, but it's not going to be a contractile tissue. Moving on to another set of homeostatic imbalances related to the heart. This is going to be the abnormal intrinsic conduction. This includes the different arrhythmias. A means without or no, and rhythm here is a rhythm that the heart is contracting with. So I have an irregular heart rhythm. Any irregularity in the heart rhythm, this is going to be considered a rhythm. Also might be an uncoordination between the atrial contraction and the ventricular contraction. If you remember, we discussed last class an example of an uncoordinated atrioventricular contractions. If you remember, we started normally by generating the electrical impulse from the SI nodes that will cause the depolarization of both atria. And then this electrical impulse is going to be traveling down from the node to the bundle, and then from the AV bundle to the right and left bundle branches. If you remember, a homeostatic imbalance that we've seen the EKG of was the heart block. What happens in the heart block? There will be no conduction or limitation in the conduction of the electrical impulses from passing down from the atria to the ventricles. So this is going to cause an uncoordination between the atrial contraction and the ventricular contraction. So the myocardial infarction definitely going to be one of the reasons why I might have a block, might cause a defect in my SI node and so forth. Yes. So a myocardial infarction can definitely cause any of those uncoordinated atrioventricular contraction. Fibrillation is going to be a rapid, irregular contractions which are useless for pumping blood. So you have very rapid, very rapid, very rapid contractions, which are not that effective even to perform any ejection. This is what we call the fibrillation. And remember, we've seen an example of fibrillation when we checked the EKG last class. And this was the ventricular fibrillation, if you remember. This was my ventricular fibrillation. You see very rapid QRSs, but those very rapid QRSs means very rapid contractions, which are not actually effective contractions. They are, yes, the muscles are contracting, but this contraction is not strong enough to pump any blood out. Remember, a person can't live with ventricular fibrillation. How about atrial fibrillation? Can I live with atrial fibrillation? What do you think? And this is how it's going to look on the EKG. You see on here, this is a normal P wave followed by QRST, P, QRST, and so forth. See on here, what happened? P, 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 P. I have many atrial depolarizations. Not everyone is going to be followed by QRST. You see on here, if you notice, not each of them is going to be followed by QRST. But if you notice on here, what happens to the ventricular contraction? Will it be affected by atrial fibrillation? And can a person live with it? Yes, like all of you said, yes. But is everyone is going to be followed by a QRST? What do you think? What do you think? Is every P wave is going to be followed by QRST? See on here, 1, 2, 3, 4, 5, 6, 7, 8, and then a QRST. So not each one of them is going to be followed by QRST, but what this resulted in terms of ventricular contraction? Am I contracting at a normal rate or not? What do you think? If I have atrial fibrillation. No, you see, I have much faster contractions. The ventricles are trying to keep up with the atria. You see, very rapid contractions, very rapid contractions. How come a person can live with atrial fibrillation? He is going to have tachycardia, definitely. So he will live without normal heart rate, fast heart rate. In some cases, you see on here, the ventricle failed to keep up with the atria, so it skipped a beat. Skip. It failed to keep up with the atrial depolarization rate in atrial fibrillation. So how come a person can live with atrial fibrillation? You see on here, if you remember, when the blood is moving down from the atria to the ventricle, what is the driving force for the blood to move down from the atria to the ventricles? What is the driving force for this blood movement? We've got two forces, right? First one is the ventricular relaxation, and the second one is the atrial contraction, if you remember. Which one did play the major role here? Which one is going to be much more effective? Which one, if you remember, going to be pulling down 80% of the blood? Ventricular relaxation. Compared to the atrial contraction, remember, it's only responsible for the movement of around 20% of the blood down to the ventricle. So, do I have a problem? Yes, I have a problem. I have a problem with the heart rate. You see on here, I have very fast heart rate. I have tachycardia. But do I have a problem with the amount of blood that I'm pumping to the organs? Do I have a problem with the amount of blood that I'm pumping to the organs? Not much. Why? Because as far as the ventricles are relaxing fine, they will be able to pull down most of the blood that I need. Most of the blood will just move down by ventricular relaxation, not atrial contraction. So even if the atria are not performing any effective contractions that helps in pumping the blood, a person can still survive, unlike with the ventricular fibrillation. I'm not able to pump the blood out of the ventricles. Moving on to another homeostatic imbalance related to the heart, which is going to be the defect in the SA node. What happens if a person has part of his heart that started to depolarize abnormally faster than the normal pacemaker, the SA node? So if part of the heart decided to depolarize at 90 times per minute, which one will the heart follow? The normal SA node that depolarizes 75 times per minute, or the abnormal, this ectopic focus that depolarizes now 90 times per minute? What do you think? Abnormal, ectopic focus, or the normal SA node that depolarizes 75 times per minute? The abnormal, exactly. Is gonna take over the SA node because it has higher depolarization rate. What if a myocardial infarction has affected the SA node? It's not working anymore. Would my heart stop beating? You remember? We answered this question last time. If no SA node is functioning, would my heart stop beating? No, right? No. Even if you lost the SA node, what's going to happen? What's going to happen? Who's going to take over? My AV node, exactly. AV node will take over. AV node will start to depolarize at its own rate because the SA node doesn't exist anymore. It's defective. So AV node takes over. If you remember, what will appear on the AKG in this case? What wave am I missing on the AKG? I don't have P wave exactly. So I've got QRST but without a P wave, no P wave. abnormal heart rate first. I'm sorry. So what happens if a person has a defect in the AV node? This might result in heart block. And remember, here, the only connection between the atria and the ventricles is going to be through the AV node. I cannot conduct electrical signals down from the atria to the ventricles unless I'm passing through the AV node. If the AV node is defective, it's not working, this is what we call here is heart block. It might be a complete block, total block, or a partial block. Few or no impulses here will be passing from the SE node towards the ventricles in case of a heart block, or in other words, defective AV node. Looking here at homeostatic imbalance related to the heart rate, a person who has a heart rate greater than 100 beats per minute, this is considered a tachycardia. Tachy means fast. If I have a heart rate below 60 beats per minute, this is gonna be bradycardia or slow heart. Brady is slow. What is the complication of having fast heart rate? Isn't it something good? Is it something good or bad first? What do you think? No, it's bad. So why? Why? Because this rapid contraction might put the heart into a fibrillation state. So the heart might keep contracting faster and faster and faster until it reaches a very fast rate in which the contraction is not effective to pump blood out. All right, so what is the problem with bradycardia? And who develops bradycardia? Slow heart rate. So if I have bradycardia, remember, cardiac output is equal to stroke volume times heart rate. If I did have a reduction in the heart rate, this means what happens to my cardiac output? Cardiac output is going to be decreased. So no blood or not enough blood will be pumped from the ventricle to satisfy the needs of the body. I have a reduction in my cardiac output. Moving on to another homeostatic imbalance of the heart. This is going to be the congestive heart failure. What's a congestive heart failure? What is, by definition, heart failure? Simply speaking, what is heart failure? It is the failure of the heart. Easy. Failure of the heart to do what? To do its job, which is to pump enough blood to the organs. So failing to pump enough blood, it's my heart failure. All right. In other words, it's going to be a reduction in my cardiac output to the extent that the circulating blood is going to be inadequate to meet the tissue needs. So I'm not delivering enough blood to my organs. What might cause congestive heart failure? If I do have accumulated fat in the wall of my vessels, and this resulted in the coronary vessels, and this resulted in less blood is getting delivered to the myocytes, to the cardiac muscle cells. What did we call this case? We called it angina, right? Remember? We mentioned it at the beginning here. Angina pectoris. So a person with angina, he has weakened cells. So the same concept on here. If I told you you're not getting enough food, what's going to happen to your strength? Would you be able to do your job if you didn't eat anything for the last 2 days, 3 days? Would you be able to perform the same as before? No. So the same concept on here. If those cells are weakened, just weakened, the ability of the heart to contract is going to be reduced. So remember, I have a reduction in contractility. And remember, when I reduce contractility, what happened to my end systolic volume? I did have, if I'm not able to contract as before, the end systolic volume did go up. There would still be blood remaining in the heart, remember? After contraction. How is this going to affect my stroke volume? I will have, as a result, a reduction in stroke volume. So what's going to happen as a result to the cardiac output? Cardiac output equals to stroke volume times heart rate. So if you have a reduction in your stroke volume, what's going to happen to your cardiac output? Reduction in the cardiac output. And this is what we call heart failure. So atherosclerosis of the coronary arteries, will cause the angina, which is weakening of the cardiac muscle cells. Weakened cardiac muscle cells will have less strength to perform contraction. As I reduce the contractility of the cardiac muscle cells, what's going to happen? Increases the end systolic volume, resulting in a reduction in stroke volume, and as a result, you're going to have a reduction in the cardiac output, which is, by definition, the heart failure. Another reason for heart failure is going to be persistent high blood pressure. If you remember, high blood pressure means I have a lot of resistance that I need to overcome to eject the blood out of my ventricle. If you remember, we call this is my after load. Having hypertension means you have high afterload. And remember, having high afterload resulted in what? Resulted in an increase in the end systolic volume. Not all the blood will come out during contraction. And remember, if you have a lot of resistance that you need to overcome, increasing the end systolic volume, what happened as a result to your stroke volume, the amount of blood that you pump per beat, you've got a reduction in your stroke volume. And remember, if I have a reduction in stroke volume, if I have a reduction in my stroke volume, this will result in what? This will result in an increase in the heart rate. And if I have an increase in the heart rate here to compensate for the reduction in the stroke volume, trying to maintain a normal cardiac output, can I keep it like this forever? So let's say you are supposed to perform 75 beats per minute. Now I am overloading you, and I told you you need to perform 100 beats per minute, or let's say 120 beats per minute. Will the cardiac muscle cells be able to keep contracting at this fast rate forever? No, at a certain point, the cardiac muscle cells will give up. And this results in heart failure. Failure of the heart to pump enough blood to the tissues. Another reason for heart failure, and might be one of the most common, is due to multiple myocardial infarctions. Remember, if I have a blood vessel, a coronary artery that has atherosclerosis, this will be narrowed, and this will result in a reduction in blood delivery to my cardiac muscle cells. And this will cause the weakening of the cardiac muscle cells. But remember, at a certain point, those atheromatous plaques in the cardiac, in the wall of the coronary vessels might rupture, and they can cause they can cause a myocardial infarction. Remember, when I have a total block of the coronary arteries, the cardiac muscle cells supplied by this vessel will be dead. And remember, those cells going to be replaced with just fibrous connective tissue. So what happens to the number of cardiac muscle cells that I have now after this myocardial infarction? So let's say I did have 10 cardiac muscle cells. One of them is dead. So now I have how many? 9. So in order for me to compensate the loss of this part of the heart, what will I do? This part is not contracting anymore, cannot contract, does not participate in the ejection of the blood out. Will those 9 work harder or not in order to compensate for the loss of this part of the heart? Would you like those remaining cardiac muscle cells to work harder or not? So let me tell you the same example, the same here, the same concept in a different story. So You have 10 horses, they are pulling a cart forward for a specific destination. But you're not giving them food. You're not giving them food. You don't have enough supply. So they are weakened, or at least few of them are weakened. Until you prevented the delivery of food to one of them, so he died. So now how many horses do you have? Instead of 10, you have 9. And you have the same load, the same preload, the same afterload, which is going to be the cart, the amount of blood that you're ejecting. Would you make those 9 horses work harder or not in order to compensate for the loss of this 1 horse? In order for you to pull the same cart in the same time to the same destination, you will make them work harder. But you still have the same problem. You still not giving them enough supply. You're not giving them enough blood here. So those cells that are still living in the heart will need to work harder. But this patient still has the same atherosclerosis. If a person works harder, if those 9 horses work harder, would they need more or less supply of food for them to be able to work harder? Would they need more or less supply of food? They will need more supply, but you actually can't supply them. So what's going to happen? Another one dies. So now you have, rather than 9, you have 8. So you're going to make them work harder, and you can't supply food. So what's going to happen? Another one will die. Now there are 7. Same exact concept will be applied in here in the heart. I can't supply enough blood to the cardiac muscle cells because I have atherosclerosis. And my body is trying to compensate for the reduction in the contractility due to the loss of those cardiac muscle cells. So the heart is going to be working harder. And this will increase the demand for blood supply, which I can supply. I cannot supply. I have atherosclerosis in the vessels. So what happens to this part supplied by this vessel? It becomes dead, and another part becomes dead, and another part becomes dead. Same sequence of events. So what happens now? What happens now? Do I perform? Can I perform enough contraction now with all those dead cells in the wall of the heart? Would I be able to pump enough blood? No. This means heart failure. Major drop in the contractility due to multiple myocardial infarctions. That's why we're going to be trying to prevent multiple myocardial infarctions. Because what is the single most important risk factor of developing a myocardial infarction? Having a previous myocardial infarction. This is the single most important risk factor. Having a previous myocardial infarction is the highest risk for developing a new myocardial infarction because the patient is already atherosclerotic. And the work demands more supply of blood. All right, so you're not looking to treat for treatment here. You are looking for prevention. You are going to be trying your best to prevent this from taking place by giving something that relaxes the cardiac muscle cells. So instead of working those 9 horses harder, I will be given beta blockers to reduce the contractility, to reduce the heart rate. I don't want those 9 horses, the remaining horses, to work harder. Just slow down. I'm good having those 9 horses because if they worked harder, what's going to happen? They will become 6, 7. All of them would be dead. All right. Yeah, not essentially. It is not mandatory that a person who got a myocardial infarction gonna have another one, but he definitely has a very high chance of developing one. A heart transplant can be a way of treatment, but this is in really advanced cases. And those patients at this age who got multiple myocardial infarction to the extent they developed a heart failure, congestive heart failure, most likely will not tolerate big operation like a heart and lung transplant. Pacemaker and defibrillator first. So here's a heart. So a person can have a heart failure and he's breathing, he's conscious. He's gonna have swollen limbs. He's gonna have engorged veins. All right, this is not a patient who is unconscious. All right, Rachel. The problem is not in the creation of the signal here. This is my concept. This is my my idea here. The problem is is not in the electrical conduction. So if you put a pacemaker, what you're gonna do? You're gonna create signals for whom to follow. The same horses, the same number of horses. You're not adding a contractile force here when you try pacemaker, right? So my problem is not in the electricity. My problem is how many cardiac muscle cells are effectively contracting to create this positive pressure that pumps the blood out. So if the myocardial infarction did affect the bundle branches, the SA nodes, stuff like this, yes, at this point, a pacemaker can help. But in this specific case where what I'm saying here, I didn't touch, in this case, I didn't touch the SA node, AV node. Those are the remaining 99% of the cardiac muscle cells. So I didn't mention that those myocardial infarctions did affect the SA node or AV node. If they did affect the SA node, yes, at this point, a pacemaker gonna be the choice of management. But here I'm talking about a specific case where a patient got multiple myocardial infarctions affecting large part of the cardiac muscle cells. The 99% of the cardiac muscle cells, those that would be following the SA node, the AV node, the Purkinje fibers. Those are the ones that will have the force, that will create the force that pumps the blood out. All right. Here, I'm not talking about specific cardiac muscle cells that got affected, which are conducting electricity. Here, I'm conducting, generally speaking, person who developed multiple myocardial infarction will have a major drop in the contractile force of the ventricles, causing him to develop the congestive heart failure. All right. Dilated cardiomyopathy is a disease that has many reasons for its development, where the heart will fail to be performing any effective contraction and will be kept in a dilated form. One of the reasons for developing dilated cardiomyopathy is a viral infection. So viral infections in some cases can cause dilated cardiomyopathy. Moving on to congenital heart defects. We're looking on here, got right atrium, right ventricle, left atrium, and the left ventricle. Now remember, what separates the right ventricle from the left ventricle is the presence of the septum on here, interventricular septum. So the first defect that we're looking at, it's going to be a congenital defect affecting the interventricular septum. So what do you think going to happen to this baby who is born with ventricular septal defect? So this is my aorta, this is my pulmonary trunk on here. The blood isn't getting oxygenated. So you're telling me that the blood coming down here from the systemic organs to the right atrium will move down to the right ventricle, right? And will be pumped. When pumped, it's going to be shifting to move from right ventricle to the left ventricle, and then going to be traveling out through the aorta to be delivered or gets mixed with the oxygenated blood. So the blood now is going to be less oxygenated, and this going to reach my systemic organs, right? Is this what you mean? All right, so my question, will the blood be moving from the right side to the left side, or from the left side to the right side? This is our second question for the in-class activity for today. A or B. Pick one, A or B. Just tell me in the comment, in the chatting box, A or B. So will the blood travel if in case of a ventricular septal defect? Will the blood travel from the right ventricle to the left ventricle or from the left ventricle to the right ventricle? B. Why B? Why B? It's from left to right. Why? Because remember, the blood normally pumped out from the left ventricle travels to where? To all your arteries, reaching every single systemic organ, to your brain, to your toes, to your abdominal organs, pelvic organs. All your organs get blood delivered by the contraction force of your left ventricle. And you can notice that left ventricle has a much thicker wall. It's going to have much larger number of muscles. So those muscles going to have a much stronger contraction force that will allow them to overcome all the systemic circulation resistance for this blood to reach all the different organs, all systemic organs. How about the right ventricle? To whom am I pumping the blood from the right ventricle? To whom am I pumping the blood? Who is receiving the blood pumped from the right ventricle? Can you remind me, please? Pulmonary artery to be delivered to what organ? What organ is it? Lungs, right? Lungs. So here, who am I pumping the blood to? I'm pumping the blood to the lungs, which are far from my heart or very close to the heart compared to my toes, for example. Am I located far or close to the heart? Very close to the heart, very close to the heart. So this means, do I have a lot of resistance against the pulmonary blood that gets ejected from the right side, or less resistance compared to the systemic side? Do I have a lot of resistance or low resistance on the right side? Low resistance. Compare. So here I'm comparing left and right. Left and right. Right side is pumping to the lungs, which are very close, and the blood will be traveling for a much shorter distance. Here, the blood is pumped everywhere. To your brain, to your foot, to your stomach, so all those vessels are branchings on here, and you need to supply all those organs which are distant, which are located away from the heart. So here, the blood that gets pumped out from my left ventricle gonna be faced with a much greater resistance. This is high resistance compared to the blood pumped from my left side, which gonna have much less resistance facing it. All right, so we agreed that the blood is going to be moving from, in case of a ventricular septal defect, as what we see on here, the blood is going to be traveling from my left side to my right side. Is this a problem? What do you think? Having a ventricular septal defect as a baby, is it a problem for the baby? Nutrients are circulating in both oxygenated and deoxygenated blood. Yeah, it's a congenital anomaly, so it's a defect in the development of the baby. It's a defect in the development of the heart. So what do you think? So most of you did say, yes, it's a problem. Actually, it's not. Why would it be a problem? You've got some oxygenated blood traveling to the lungs, and the oxygenated blood is going to be delivered to the left atrium. So it will not harm the lungs to get some oxygenated blood with the deoxygenated blood. It's not a big problem. It's not a big problem. Patients at this age will not be manifesting any signs other than the murmur. Will it be bad if not treated? What do you think? This is my first question. My first question was, is it bad at that time when the baby is born or early in age? And the answer here is that it's not a big problem. It's not a big problem. How about later on? Later on, if it was left untreated, will it be a problem? So normally the oxygenated and deoxygenated blood are not mixed in the cardiac circulation in here, but this is a defect, this is a disease, this is not something normal. All right, why is it going to be a problem if was left untreated? This is my left side of the heart. This is my right ventricle. And this is my interventricular septum. All right, so you see on here, the right side has much less muscles compared to the left side. But what happens when you add, every time you contract, you add some blood to move from the left side to the right side? We did agree it's not an oxygenation problem. Remember, all this blood coming from the right ventricle is going to be pumped towards your lungs. So it's not going to be a problem getting some oxygenated blood passing from the left side to the right side and to get delivered to the lungs. It's not a big deal. But when would I have a problem? Later in life. Why? Because every time, rather than pumping, let's say, 10 liters or 5 liters per minute, rather than pumping 5 liters, you add 1 liter that has traveled from the left side to the right side. So rather than pumping 5 liters, now I'm pumping 6 liters per minute. Is it a problem? The heart can accommodate it, and it will be pumping this extra load towards the lungs. But what happens if you overload a muscle, if you kept it trained? What happens to your biceps if you kept training your biceps? Hypertrophy. If you go to the gym, you train your biceps, what's going to happen to your muscle? It's going to become larger. Will it be weaker or stronger over time? If you kept training your muscles, what's going to happen? It's going to become stronger. And when it becomes stronger, this is a problem. When the right ventricle is now stronger than the left ventricle, this is what will cause the problem. Now, the blood can travel from the right side to the left side. So over years, this added blood from the left side to the right side will increase the strength of my right ventricle. And when the right ventricle becomes stronger than the left ventricle, what's going to happen again? Blood is now going to be moving from the right side, the side with higher pressure, to the side with lower pressure now, which is going to be my left side. And why will it be a problem now? Because now I am delivering this deoxygenated blood mixed with the oxygenated blood to my brain, to my liver. Now some deoxygenated blood is mixed with the oxygenated blood, which will reduce the oxygen partial pressure in the arterial blood that gets delivered to all the different systemic organs. So here, delivering some oxygenated blood to the lungs, it was not a problem, but over time, what happened, the right ventricle becomes stronger and creates a pressure greater than the pressure of the left ventricle. Now the problem takes place because of the passage of the deoxygenated blood from my right side to the left side. Once it travels to the left side, it will then be delivered to all systemic organs. Any questions? Any questions? Does it make sense? All right, so interventricular septal defect, or VSD. So you're gonna have here after the shift, all the time there will be a murmur that a person will feel on his chest. You can hear like sound, an extra sound. It's gonna be intense, especially if the defect was smaller. The smaller the defect, the louder the sound that gets created. But when, after years of no treatment, becomes an Eisenmenger's syndrome, so now the blood is moving from the right side to the left side, I will have bluish discoloration of skin. I will have clubbing of the fingers. So the fingers will become bulging towards the end, like drumstick fingers. And those are the nails on here. Over time, this might cause heart failure with all the symptoms of heart failure if not treated early. Patient will have shortness of breath. He will have inability to compete with the other children of his age because less oxygen gets delivered to his muscles, less fatigable, and so on. All right, so again, ventricular septal defect. The interventricular septum fails to become fused, and so the blood mixes between the two ventricles, again, early in the disease. The blood is moving from the left side to the right side. Late in the disease, if it was not managed, it's going to be moving from right to left, and this is going to be right to left shunt or Eisenmenger's syndrome. Another congenital, another cardiac congenital defect is the coarctation of the aorta. So here we're looking at this going to be my left ventricle and right ventricle. And this is going to be my aorta, like this. The baby here will be born with constriction in the aorta, so narrowed aorta. So what do you think? Would I have, in terms of resistance, facing the blood flow coming out of my left ventricle? Would I have high or low resistance compared to normal? If I'm telling you I have narrowed the diameter of the aorta like this. This is my coarctation of the aorta. This is a coarctation of the aorta. Will I have more or less resistance, high or low resistance, facing the blood flow? So which one applies more resistance, a large artery or a small artery? Blood is faced with much greater resistance passing through this narrowed part of the aorta. So having high resistance that I need to overcome, what did we call the pressures that I need to overcome in order to pump the blood? Can you remind me? This is going to be my afterload. The same as what we've discussed earlier with hypertension. So this patient is going to have reduction in stroke volume and so reduction in the cardiac output. This will be compensated by an increase in the heart rate. It's like a baby having hypertension from day one. It's like a baby having hypertension from day one. So the aorta is going to be narrowed, and this is going to be increasing the workload of the left ventricle. A much rare congenital anomaly in the heart is the tetralogy of Fallot. See on here, tetra means 4. this patient gonna have 4 defects associated with the syndrome on here. First is a VSD, ventricular septal defect. Another one that has that be part of the tetralogy of Fallot is that it has narrowed pulmonary trunk. A third defect is that the aorta is overriding, and the last defect here is going to be hypertrophy in the right ventricle. So let's see on here. What is the problem with this patient? See, this is my right ventricle. This would be my left ventricle like this. This is going to be the pulmonary trunk. And here is the left atrium. And the aorta is going to be traveling like this. All right, so the first defect that we see on here is that the interventricular septum has a defect. So normally, if it was a regular VSD, the blood will flow from the left ventricle to the right ventricle, right? This is what we mentioned earlier with VSD. Blood normally gonna be passing from left to right. But if you notice on here, I have other defects. I have narrowed pulmonary trunk. The base of the pulmonary trunk is narrow. And the aorta is overriding, means it's gonna be receiving blood from right and left. It's overriding the right and left ventricles. The last defect associated with Fallot in here is that the right ventricle is hypertrophied. So I have hypertrophy of the right ventricle. So you see on here, which one would you pick to go to as deoxygenated blood? On the right side. Would you like to go through a narrowed pulmonary trunk or a wide aorta? Which one would you pick? See on here, the aorta is expanding its arms, welcoming you, overriding aorta. So which one would you go to? Definitely more blood gonna be going to the aorta. So this is a baby that will have bluish discoloration of the skin from day one. Why? Because of the delivery of the deoxygenated blood to the systemic organs. And again, it's not only about a VSD. VSD is one of 4 defects related to the tetralogy of Fallot. Again, what are those defects? VSD, hypertrophy of the right ventricle, narrowed pulmonary trunk, and overriding aorta. All right. Any questions? 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 All right, we can have a break for 10. We come back, discuss more about the cardiovascular system. Any questions before we go for a break?